Hello, good morning, good afternoon, and good evening, everyone. Thank you so much for joining us today. We are thrilled to welcome you to the DAC Healthcare System Preparedness Learning Laboratory. We have a great lineup today, and I'm very excited to kick off our discussion. So I'll start, and I will tell you a little bit about who we are and what we do. And then I'll tell you a little bit about why we do it, and then I'll give you an overview of what we'll talk about today. So the Davos Alzheimer's Collaborative System Preparedness Program, or DAC-SP, was created with a simple but urgent goal, which was to help healthcare systems around the world become ready for the future of brain health. And so in terms of why we do that, the last decade has brought very significant innovation and change in the Alzheimer's and dementia space and the brain health space. In the last 5 years, we've seen an acceleration of diagnostics and treatments that have hit regulatory milestones. And yet we know there's a very significant uptake gap between good quality evidence of what we can do for patients and the ability of health systems to be able to absorb tools and sort of serve patients and families at bedside. And so for us, the last mile of making sure patients and families benefit from these new diagnostics and treatment is sort of the rallying cry of what our programs are aimed to do. So we work directly with health systems. We've got about 70 sites globally, over half in the US, to really understand what it takes for systems to be ready. And so in the US, over the last 2 years, we've learned a lot from our fantastic sites. And so we sort of see readiness as a three-legged stool that combines workflow and workforce development as one leg, billing and incentives as another, and IT and infrastructure builds. And so there's no one-size-fits-all approach to how systems sort of metabolize this change. And there are big differences depending on the capabilities and resources of the system and where patients are managed. That brings me to what we'll talk about today. So one very high leverage model that we've seen systems employ that is really exciting is the Brain Health Navigator model, where systems are able to orchestrate patient access, provider capacity, and resources to make timely, coordinated, and person-centered care. So today we'll unpack the why and how of the Navigator model with systems on the forefront of innovation who have adapted this in the real world. So this morning we'll start by hearing from leaders who are helping define what the Brain Health Navigator model could mean for healthcare systems and why early detection has to be a system-level priority. And then from there, we'll hear directly from a group of sites and system leaders who are implementing this work on the ground in the US and who are developing and refining the Brain Health Navigator model with DAC-SP. So throughout the meeting, I'd encourage you to think about how these insights may apply to your own systems, the barriers you see today that a Brain Health Navigator model could be really impactful in helping to remove. So we really appreciate your time, attention, and commitment this morning. And I'm now very excited to turn the conversation to our first discussion, where we'll talk about the power, promise, and potential of the Brain Health Navigation model and how it has the potential to transform how systems approach brain health from early detection to coordinated care. And so, I think when we think about the why of the brain health model, our early flagship programs in early detection really showed us that there was three really pervasive challenges in primary care. So providers are under immense pressure, lack the time, and often have low confidence and tools to diagnose cognitive decline. Patients often get lost in the system, missing appointments and follow-ups, showing up in emergency rooms and falling through the cracks. And families really struggle without clear guidance or connection to support resources. So the Brain Health Navigator model really has the potential to impact each of those axes so that patients and providers are able to provide and access more timely coordinated care. So Indiana University and IU Health have been leaders in advancing early detection and longtime partners of DAC-SP. And insights from their flagship early detection program were really the genesis of our Brain Health Navigator program. So we have stood on the shoulders of giants and really owe a debt of gratitude to IU for their work on this model. Today we'll hear an executive perspective on what will what it takes to move this model from vision to real world impact. And with that, it's my pleasure to introduce the speakers today who will be joining me in this fireside chat. So Dennis Murphy, who is the CEO of IU Health, and Dr. Lori Gutman, who is the chair of the Department of Neurology and professor of neurology at IU School of Medicine. Welcome both.
Hi, Tim. Good morning.
Good morning. It's great to have you. So Dennis, I'll start with a question for you. So in thinking about the future of healthcare, what makes early detection of cognitive decline a system-level priority that supports population health and value-based care goals?
Yeah, I think it's really important to kind of understand the baseline that more than half the people with Alzheimer's disease or related dementia go undiagnosed. And so this really starts with, missing that diagnosis or getting that diagnosis late really prevents us from identifying treatments that those patients would be eligible for. They end up having worse symptoms with the disease that they have. It makes their comorbidities more complex and typically have worse outcomes because of it. We can't do much advanced care planning because I think it's different in this patient population. And then I think importantly, you can't connect patients to clinical trials that they may be eligible for and help advance the field. So, for us, I think this is really about a core belief that we exist to make the state a healthier place and that these patients are going to continue to have unique needs that we need to identify earlier to get out ahead of that.
Great. That's a really good snapshot of sort of why it's a priority for your system and why it should be a priority for other systems. And I'm curious when you think about how can systems more effectively integrate cognitive health into routine primary care? And, what's your perception of how a brain health navigator model may help in making that a reality?
I always think it's a little ironic every time we all go to a primary care physician or any other physician, the first thing they do is take your blood pressure to check for hypertension. And yet we don't think of people's brain health in the same way, where there isn't routine screening to understand how we could actually prevent or help those patients. So for us, the brain health navigator role has been a critical component because I think every primary care physician wants to do the right things for their patients. But what they find is that they get overwhelmed with what do they do next if there's additional support when somebody screens positive. Because they've got full schedules, they're managing a whole host of complex chronic conditions, and they need an expert. And so I think that's where the behavioral health navigator has been essential to really connect them for further evaluation. How do they get the right care pathway depending on their disease state? How do they connect to community resources? And just how do you make the patient and their family feel like there's a plan? And so that's more than a typical primary care physician can handle. And having somebody who's expert in that space and really a resource for the patients and their families is essential.
Yeah, and I think you sketched out the how of change very nicely, where there's the human component for both providers and navigators, as well as a systems component. And, I think that type of transformation work is really challenging. It's got that cultural and operational component. And so I'm curious, sort of in your journey as CEO, as you've adopted early detection, what levers of leadership in terms of structure, incentives, or storytelling have been really powerful in creating lasting change at IU Health?
Yeah, and you probably hit on it, Tim. It's never one magic solution. I think it's all I think we're proud to say we're a kind of values-based organization, and we look at our mission to improve the health of the entire state. And this idea that every single patient deserves the best care that's designed with them as part of that process. So there's a bit of the purpose of why are you in healthcare. I think there is a structural component that we measure ambulatory quality, and part of that is actually how we think about screenings. So, actually, structurally measuring, monitoring, and understanding what we do. And then I don't think there's anything more powerful in terms of reinforcement than storytelling, which is really having patients and their family members talk about what life was like before diagnosis and what life is like in a structured program and the difference it makes to really reinforce. So those very personal stories are critical.
Yeah, that's great. I remember, when the flagship program was happening at IU Health, Dr. Dee Dee Willis, who was leading it, to your point about measurement, I remember a meeting where she stood up and showed us like a run charts of where the DCAs were happening in the clinic. And where there was dips, she had someone would go and remediate, and they had a really sophisticated understanding of, a stylist didn't get charged, or there was a changeover in staffing and we needed to go in and change. So I've always been very impressed by the work that your teams have done in this space. It's really, really exemplary.
Yeah, I think you got to have a little bit about the heart and the head.
Yeah. So Lori, turning from you, so as we talked about, IU has really been at the forefront of early detection and diagnosis of Alzheimer's disease. From your perspective, why is now the right moment for healthcare systems to invest in a brain health navigator model? And what are some of the key gaps in detection and care this model could help close?
Yeah, well, I mean, I think, why now it's so important is for a couple of reasons. One is the obvious one that we are heading into an era of actually disease modifying therapies and potentially even going on towards not just disease modifying, but treatment and reversal in the future. But the earlier you can involve the earlier you can identify patients, the better, chance you have of making a meaningful difference. If, patients who are later on in their disease are going to, not be eligible for some of these, or maybe not respond as well. And we have an aging population, right? So we are going to have more and more people who are needing this. I think as we think about also, the efficiencies of care for ourselves and our patients, right, as we take care of patients better, having the ability to do this in concert with the primary care physicians makes such a difference, as Dennis already mentioned, right? Being able to identify the problem in the primary care physician office and then having a pathway to move the patient forward. This is really a key time, I think, for that. We have technology to help us now that didn't help us before, that wasn't available before. Not that it didn't help us, maybe it didn't, but it wasn't available before. And
Yeah,
and that gives us all sorts of other opportunities as well.
great. And Lori, you sort of have a unique perspective sitting in a system that has implemented a navigation model for years at this point. And so I'm curious, throughout that experience, what you've learned about the power of embedding the dedicated navigators into the patient journey and how that sort of has had impact on both patients and care teams.
Yeah, I will say, first off, that we are really fortunate. I mean, as the head of an academic department and part of the health system, the partnership between the health system and the academic school of medicine is key for some of the success that we've had here. We were able to bring together people who were part of the system, people who were who were in the front lines of finding, treatment research, and put together a program. I think, some of the things that we really had to do initially was, not surprisingly, break down silos, right? And the first step, you mentioned Dee Dee Willis already. I mean, the first step was really to engage the primary care physicians who really, and Dee Dee as a primary care physician was key in helping us build that bridge between the neurology system that wanted to do this, but didn't have necessarily capacity to be there. And then we had to bring in all the systems people. So who else was involved? The pharmacists, the social workers, the neuropsychologists, everybody who was going to need to help shape this. So that was the biggest task. And in the beginning, we got pushback initially from the primary care physicians who said, okay, first of all, I don't have time, but if I do this, if I do have time, like, I'm not comfortable knowing what the next step is, and if I do identify someone, how do they get into the system? So there were lots of different things. It gave us a different view of how our system worked as well. And again, with a lot of operations and health system people together with the physicians and the brain health navigators themselves, we really had to work through how to embed people into the first clinics and then how to make it work. So it really, not surprisingly, took a whole team, still continues to take a whole team. Jared Brosh, if I didn't mention him, Jared and Dee Dee really, along with Dustin Hammers, one of our neuropsychologists, and Donna Wilcock, just really came together and said, we're going to solve this. How can we solve it? And the system was really helpful in that.
Great. And so I think a question for both of you, Lori, I think you sketched out really nicely how the navigator model in primary care was a bit of a forcing mechanism to bring a lot of practice areas and organizational resources together to sort of solve a care pathway with a lot of complexity. And, as you've lived with the model for a few years and are a little further ahead than other systems, how would you see this role evolving? And, what do you think it would take to scale it sustainably across large, complex health systems?
I can start, and Dennis, you feel free to jump in. But I mean, the sustainability part is definitely the concern for long term. I think, one of the things that we have looked at is, what kind of financial resources or how can we utilize different types of complex coding? I mean, that the system has worked so well that, we are, our brain health navigators are super busy. And we've learned a lot of lessons on how to triage people. The key thing is to make sure that if, it's not just about disease modifying therapy, it's about everybody. So if they don't qualify for a disease modifying therapy, what other resources do we have? And so, the sustainability is working with our other partners in geriatrics and in primary care to make sure we have resources and people to sort of catch everyone who goes through the system.
Yeah, Tim, I would just say I think the kind of financial model for this works better in a population health model where you can really see sort of the downstream benefits of other comorbidities being managed more appropriately and getting these patients into the right therapeutic regimens or care models that they need. The other kind of scalability idea for me, I do think there is a technology component to this, whether it's AI, machine learning, or even just automation of simple survey activities that we see as essential to kind of making this work at a bigger scale as well. We've done well, but I think Dr. Gutman and others would say we still aren't touching all the people we need to or want to. And so I think understanding technology and its use with this population specifically is going to be an interesting kind of course to go through and figure out, can we effectively use that as part of the solution set? I don't think you replace the human component, but I do think it allows you to scale and make the people involved capable of managing bigger populations of patients.
I agree, that's a big component.
Great. Well, I want to thank you both for joining us this morning and being so generous and sharing your experience and learnings with our audience. Thank you so much. It's been a delight speaking with you.
It's been an honor. Thank you.
Yeah, thank you for inviting me.
I would now like to invite Special Advisor to DAC SP, Dr. Phyllis Farrell, who will lead us into our final discussion for today's meeting.
Hi, Tim. Thanks. And I always laugh when you call me Dr. Phyllis Farrell. So thank you for that. But a big thank you to Lori Gutman and Dennis Murphy and the entire team at Indiana University Health. It took some courage when we gave them that first call and said, would you all do this with us? Sometimes when you're on the cutting edge, it could be the bleeding edge. And we certainly learned a lot together, but the whole team there has been amazing. And we continue to see Indiana University out in front. But one of the things that you heard and saw when you listen to them is the tenacity of a champion. And in their case, you had champions in primary care, in the medical school, in the health system, in the leadership, even in the project management. Everybody saw a real value here. And we continue to see across all of our programs that the #1 success factor is a tenacious champion. So I'm really excited to introduce you to some more tenacious champions in the panel today. But first, let me give you a quick overview of the Brain Health Navigator program. And so basically what we found when we ran our first 7 programs, it was across 6 countries, and they all really had something in common. And that was they had to create these boundary spanning roles. The system and the workflow was janky. And yes, that's the technical term. We're in an immature space where the workflows for brain health navigation and for early detection and even for Alzheimer's in general were really pretty broken. So all of the systems were using the grant dollars from the Davos Alzheimer's Collaborative to create these boundary spanning roles. We knew that that was not a sustainable model. And so what we created with the help of the folks you're going to hear from today is a brain health navigation model in the US. So let's take a look at what does Davos Alzheimer's Collaborative do. Tim's told you a little bit about this, but basically we know that there is a persistent adoption gap across all therapeutic areas where it takes 17 to 20 years for new innovation, whether those be diagnostic or therapeutic, to get to patients. And none of us believe that we have that kind of wait time. So our goal is to basically fix the tracks so that these great new innovations that in here are represented as high-speed trains actually have good systems to run within. So when you look at our model, you'll see that there are really 2 areas of focus that we have been working on. The first is around screening and early detection of cognitive impairment. And then the second is accurate diagnosis of what is causing that cognitive impairment. This 1-2 punch is what we really need to deliver on to make sure that people who have cognitive impairment are getting the kind of care they need, like Lori was talking about, no matter what kind of care that is or where they are in the disease progression. So in the screening and early detection, we've completed the flagship program, which you heard about today from IU and several other systems, and we're now in dissemination and launch across multiple other systems. We're enrolling right now in the Accurate Diagnosis program. That program's being taking place in 8 sites across 5 countries. So stay tuned for more there. So let's talk about the US. DAC is a global footprint. We have over 70 sites in 18 or 19 countries now and 5 continents. However, today we're really going to be focusing on our US footprint, which is where about half of our sites reside. So this is a list of how the program has rolled out since 2021. So in addition to those 36 sites, we also have countless examples of catalyzed activity. If you haven't signed up for our newsletter, please do so. They come out 3-ish times a year, and you'll be able to keep touch of what's going on. So the Brain Health Navigator program, as I mentioned, it was really catalyzed by the work we saw in that early detection flagship program, including at Indiana University. The goal here was to get some forward-leaning systems who were already using some of the advanced diagnostics and work together with them to create a toolkit that could be replicated, sustained, and paid for through existing medical channels. Philanthropy is not the only way to make sure that people get care, because if we allow that to happen, we will continue to reinforce a situation where the quality of care that you get matters by your zip code. So this Brain Health Navigator program that you're going to hear about today really is intended to create a model, not an individual person. We thought it might just be an individual person, but as we all know, things are more complicated than that in our US health system. So it's really a model. It could be an individual, it could be a series of individuals that are all doing different jobs, but essentially they roll together to create a model of navigation for a patient and a system to move through the steps of the diagnostic journey in a way that is effective, efficient, and make sure that we're getting the right patient, the right care and treatment that they need at the right time. So we had over 30 applications for this particular program, and 6 sites were selected. They have a lot of variability, which is what we were looking for: academic, non-academic, Midwest, coastal, rural, pop health, neuro, primary care, you name it, you've got some aspects here. So this is who you're going to hear from today. You don't want to hear any more from me. You want to hear from them. One thing I will say that's very important is we know that local law and regulations differ significantly by state, within health systems, in some cases even by county. So we're going to give you these examples here, but recognize we know there's not a one size fits all, and that ultimately all clinical decision making and all billing decisions should be made by local experts. So I am going to hand over here to our first team member that you're going to hear from, and that is Dax, who's going to be joining us from Dartmouth. Dax, I'm going to hand it to you.
Perfect. Thank you, Phyllis, and thanks everyone for organizing all of this. It's great to be able to speak with everybody from the SP program and kind of share a little bit of what we've done within our system, and I look forward to hearing about all the other systems as well. I'm joined in this effort at Dartmouth by my collaborators, Corey Crane, who is a geriatric psychiatry nurse practitioner, and Karen Blackman, who is also the co-site lead, who is a neuropsychologist. And what we really aimed at is trying to use this model from DAC to create a model within our own system that improves the diagnostic journey for people with cognitive difficulties, at the time at the time that these issues are picked up, say in a primary care office, all the way up through towards diagnosis and further referrals. And this is just our own experience within a large academic health system, but one that is housed in a very rural area of northern New England. We are the largest healthcare organization in the state of New Hampshire, but knowing that it's challenged by, we have this major center within Lebanon, but we're surrounded by a very rural population. I think something that we have in our favor is that New Hampshire, Vermont, and Maine kind of trade each other every year for the oldest states in the country. So this is something that our leadership within Dartmouth Health really understands is going to be a pressing issue. We redid our strategic plan this year, and novel care delivery pathways for older adults is at one of the top kind of parts of our strategic plan. The way this is organized here is that cognitive care within Dartmouth Health is shared by geriatric medicine, geriatric psychiatry, and behavioral neurology. We coordinate across those specialties, but we decided to house BHN within our own section of geriatric psychiatry, partnering closely with our groups in primary care and general internal medicine at some of the sites at DH as well, with the overall goal of developing one referral pathway through diagnostic care to get an early and accurate dementia diagnosis or understanding of what's causing someone's cognitive impairment. So a busy slide. I'll walk through this quickly of just kind of understanding exactly what we're trying to do within our health system. What we really want to focus on is that if this comes up at a primary care provider visit, a patient mentions something, their loved one mentions something, something gets screened on, such say, a mini cog or a MOCA at an annual wellness visit, we want to be able to take the primary care provider's concern and say, this is the place that all of these patients go. They don't have to scratch their head and understand, would this patient be better served by neurology or medicine or psychiatry? They know where to refer these people to. These end up in a registry. We have an initial appointment, hopefully as soon as possible, with our brain health provider and then our brain health navigator. The way that we've structured this is a nurse practitioner for the brain health provider and an RN for the brain health navigator. We're looking at that potentially being a social worker as well at this point. And then these patients are scheduled for this initial cognitive care appointment, which is fairly structured, but I think we've structured this so that we can capture as much information as possible off the bat to get people as far as they can, without having to come back for a lot of other appointments. That involves a pretty detailed history, a review and assessment, functional screening, seeing how the caregiver is doing, and then also getting a sense of brain health overall, knowing that, even if there is a diagnosis, there's certainly things that we can do and intervene on from a brain health perspective that may reduce the risk that this progresses or slow down the progression overall. This initial cognitive care appointment is tied closely with neuropsychological testing, a briefer panel than what may be done with full neuropsychological testing, but we felt that's very important to come up with a cognitive phenotype of understanding, does this look more like Alzheimer's disease? Does this look more like frontotemporal dementia? And that helps us aim our referrals from there. After this appointment, a lot of these recommendations are referred back to the primary care provider of saying, we think that this may look like Alzheimer's disease. We would like to see a PET scan or biomarkers, and then putting together a recommendations package for the primary care providers in our electronic health record system where they can see the recommendations as we would order them and then sign off on them as appropriate. And that may include referrals for procedures such as a lumbar puncture, as well as referrals to specialty care, neurology, geriatric psychiatry, geriatric medicine as appropriate. And then what we're hoping to do is really allow this brain health navigation to serve as the entry into a more comprehensive dementia care program that really spans the disciplines, aiming at longer term kind of care management for both patients and caregivers in collaboration across these specialties, and then also looking at treatments. Certainly looking at the broad spectrum of treatments for dementia, as well as the new disease modifying treatments that we're starting to offer as well. We can go ahead to the next slide, Phyllis. And then I think the takeaways from this, as far as successes and kind of quick wins and opportunities that we see, as well as some challenges, is that we were very quickly able to work with our team to get a lot of this done in Epic, which is the EMR that we use. And we've also been able to help use this to get the referrals to the right place. We found and kind of joked that we get a lot of referrals for quote unquote memory, and that really doesn't mean anything. That person might be better served by one specialist versus another, and this is a very effective way of sussing through that and understanding what to do next. We found it really helpful for bringing people in for these cognitive care and brief neuropsychological evaluations. It's getting a lot of care done, especially in a rural setting where patients may be driving in from a distance. It's nice to be able to get this done quickly. And we've been able to very quickly get a lot of system buy-in and even some dedicated FTEs for our staff at this point, which we're very happy with. We've seen a steady increase in referrals, but with that, we've also noted some challenges as far as getting our administrative support up to speed with regards to how to do these linked appointments, how to get these scheduled accurately, and making sure they're going to the right place. We found that it's been a little bit more challenging since we don't have anyone dedicated to advertising to get the materials made for our primary care providers. And I think at the end of the day, the real challenge remains is trying to bridge these silos across different departments with this overall goal of having an easier to navigate health system for these folks, and then building up these navigator positions as part of a comprehensive dementia care program.
Thank you, Dax. I love you brought up the need to partner with IT. I think we find this time and time again across all of our sites is one of the things that people underestimate how important that internal partnership is. The other thing is I did get asked in the chat, will these slides be made available? They will be, as well as a recording, so everyone can know that that's there. And also some questions about what is a brain health navigator. Well, you're going to hear about that today. And how do you find out or learn more? So at the Davos Alzheimer's Collaborative website, or the DAC blueprint, you'll be able to link into the tools that this group created, and we will provide a QR code for that link at the end of this, or you can find it at dacblueprint.org. So I'm going to move to our next speaker. Kara, you're up. I think you're on mute, Kara.
Thanks. I'm a neurologist at Memorial Healthcare, and we are in rural Michigan. This is my fantastic team. And just to point out, Sarah Veith, who is the brain health navigator that is in our primary care center. And then we have 2 neurology brain health navigators. We sort of mirrored this in our own neurology clinic as well, that we'll kind of talk about how that relates as well. And that's Tina and Shaylin. I'm gonna go to the next one. So Memorial Healthcare is in rural Michigan. However, we do have referrals that come from more urban areas closer to Flint and Lansing, Lansing being the capital of the state. But we have the Brain Health Navigator was actually set to be in our largest family medicine clinic. And we have a number of providers that work in that clinic. And now we're working on how to branch that out and how do we get Sarah, the brain health navigator, to be either go to other primary care physicians' practices in more of the outer areas of the county, or do we have those patients come to her? So one of the things that we're kind of still working on, because we do have such a large county, we're the main provider of neurology care, but also we have kind of clinics that are sort of spread out. We can probably go to the next. Okay. So we wanted to have a registered nurse with an understanding of the diagnostic and therapeutic pathway for Alzheimer's based in primary care to help facilitate referrals to neurology, improve the quality of those referrals, and then also to better have an idea of who needs to actually have a referral to neurology and who might be better suited to have a referral to palliative care or to actually stay within the primary care clinic itself. And I think this has been an added sort of bonus of the program, is that as our wait times in the neurology clinic have increased, this is a way within our own health system to help reduce some of those, making sure that the referrals that are going to neurology are really those earliest stage, most likely Alzheimer's patients that we're able to work through, and some of the more advanced stages of dementia going to another avenue of care. Early on, we thought that this could be a part-time position. It's a relatively small clinic, but learned very quickly that this really needed to be a full-time position because we really wanted, in addition, that availability. So Sarah actually is present in that primary care clinic, and that the primary care doctors can actually just come out of a room and say, Sarah, I've got somebody that I'd like you to come in and see. And then right there in real time, while they're already in the clinic, she can go in and talk to that patient. So I think that that's really improved the compliance issue with having to later call someone and actually schedule an appointment, is that it's an actual truly handoff from that primary care physician directly to that nurse, where he can express his concern, she can come in and address it immediately. So I think that's been an advantage that we have in a relatively small health system and in this situation, and that we have Sarah just in the practice itself. Let's see. So Sarah did spend she spent a couple of weeks with us in the neurology clinic, saw patients with me, got to know the neurology side of that as well. So has some actual contacts within the clinic, and most importantly, the contacts with our own patient navigators in the neurology clinic, so that they can have, it's not a physician to physician, but also a brain health navigator to brain health navigator handoff to transition that patient from primary care to get that specialty care. So now we can go to the next one. So this is what we kind of designed with Sarah, and what would we really like to have in a referral from primary care? What are the things that we're looking for as neurologists? And what then at the same time will we be able to then educate and support primary care to do in their own clinic? So Sarah does a lot of this initial evaluation that might be a first appointment when you see a neurologist about your memory. She's actually doing a lot of that, which means that some patients, something is found, they don't need to go to neurology because it's treated within the primary care. And we already have this information. I think in seeing the patients that have come through Sarah and the Brain Health Navigator program from that primary care clinic is that it saves one whole appointment with neurology. I am at an appointment number 2. Basically, when I'm seeing that patient. In fact, now when I have all of this information, I say, oh, this must be someone that Sarah has worked up in primary care, because it's unusual to have so much information at that first appointment, but really sets us up for a really good, positive and purposeful first appointment with the neurology. I think we can go to the next maybe. Okay. So I have engagement of primary care both for an opportunities and success and challenges, because I think this is as Phyllis wonderfully says, this tenacious champion, but that tenacity we have to have then be contagious to really expand the program. So I think that it's great and really wonderful to find that champion, and that's so key to the success of this, as you pointed out, Phyllis. But then that person also has to expand that up, sort of picture the amoeba, as we're kind of including more and more people into this. And we can expand that. So we have found those tenacious champions, and now we're really working to make sure that we have those champions maybe in every primary care clinic that's included in this program. I think that one of the things that's been fantastic is that we have had more of that communication between departments, and that's always been an issue with physicians. We don't like to communicate, don't like to call each other up on the phone, but because of this, it's facilitated from a physician to physician standpoint, but also, as I mentioned, that patient navigator, brain health navigator, and primary care, and also that direct communication with our brain health navigators in our clinic, where we have the brain health navigator call up and say, I have somebody who's really early on, I'm worried about them, everything's come back normal. Do you think that maybe we can triage them into see the neurologist a little bit sooner? So some of those things have been really key. And again, it's something in a small health system that you're able to do in larger places might not be able to, but that's been really key for a few, particular cases where we've gotten people on anti-amyloid therapies a lot sooner because of that. Let's see. And I think one of the things that I have, thought about as well, and if I was to do this whole thing again, how would I do it differently? And one of the things that I personally think I should have started with is really that education to the administration. We just heard from IU, and the administration understands this and they get it, and they're wanting to help with that problem. Sometimes the administration just doesn't really understand what the problem is, where we're at in the field of Alzheimer's disease, and where it's going in the future, which maybe is the most important thing for understanding why this and why we need to expand this kind of navigation in our clinic. So I would have started with a meeting to try to describe where we're at in Alzheimer's disease, where we think we need to go, and how we really need to support primary care to get the best results for these new treatments that are coming out. Okay, I guess that's it.
Thank you, Kara. I love that you talk about having your brain health navigators both in primary care and in neurology. That's actually a similar type of model to what Indiana University does. And often the two of them are talking to each other, and they're basically triaging for you. So to use an accounting term, you're not using FIFO methods to see who comes into the neurologist. You're making sure that that neurologist time is not just the second appointment, but also that the people that get to neurology are the ones that really need to get there, as opposed to folks that might otherwise be making the delays to see neurology longer than they need to be. So thank you for everything you're doing. I'm going to move next to Janet from Sharp. Janet, take it away.
Well, good morning, everybody. It's a little earlier here in San Diego, California, but it's a beautiful day out. I'm privileged to work with this team. We are in San Diego. John Clark is our Chief Population Health Officer, who really instigated this whole process for us. He was unable to be with us today. I'm the Director of Population Health. Sarah Ferrara is our social worker and our brain health navigator, and Scott Heimer, who's also on the call, is our project manager, who's done a great job helping me get this underway. Okay, next slide. Okay, we are in San Diego, and we're a big health plan here and hospital healthcare system. We have 3 medical groups. We're one, Sharpey-Steele. We have 5 hospitals in San Diego that we're affiliated with. We have many locations for our different primary care clinics throughout San Diego where people can receive multiple services under one roof. We are on Epic now. We went live last year, March, and it was a journey, and we like it very much. It's made some great improvements, but it's also slowed us down in some areas too, but we're getting better and better at it. Our total membership within Sharpey-Steele is 345,000 patients. And what's really nice for us is that 70% of our population is managed care, which makes it a lot easier in many ways to care for our patients. We are a foundation model, so our physicians all work for the medical group, which also makes it a lot easier to start programs and follow up on them. Our model is integrated with population health. We have a very robust population health program here at Sharp, and I'm very proud to be a part of it. And we support all of the primary care physicians, specialists too, but mostly we work with our primary care physicians in closing care gaps and managing care programs, providing education, and meeting the needs of their patients. We really support them in many areas. We started this endeavor with existing staff and still using existing staff and referral processes for seamless integration. Everybody that works here at Sharp knows population health, knows who we are, knows key people within Pop Health, and know how to refer, how to contact us, how to ask questions. We round with them. So we felt this was a perfect way to introduce the BHN model. Okay, next slide. Okay, we have a very simple diagram here compared to some others. And we struggled with it a little bit in the beginning because we haven't done anything like this. And this is a reason for everything that's been said today already, that we really wanted to start something here at Sharp. So we started very simply using a model we already have in place for other programs, and we're making changes along the way. So we piloted at one site, at primary care site, and that site had social workers embedded in the site, and we've done other behavioral health programs with them, so we felt that was the best site to engage the doctors. We usually pilot new programs in one site because we kind of work out all the kinks and get all the questions answered before we spread to the whole organization. So we weren't getting a lot of referrals. We weren't getting any referrals, even though we talked a lot to the physicians about it. So we started pre-screening patients that were 65 years and over a week before they came into their primary care visit. And we would send them 3 pre-screening general questions about forgetting appointments and not showing up for events, losing words and not being able to find words, and losing a lot of things, which sometimes that happens to me too. So, but we general questions to kind of get some answers to our patients that were coming in to spark a conversation. And it kind of had a good effect because we were able to notify the physicians when the patients came in to screen for them or to ask a few questions. And again, we've always said to our docs and our clinic staff that if anybody comes in with concerns, cognitive concerns, family members come in, I notice a difference in mom or dad, that we would like those as referrals. So they would send a referral to our team in population health. It goes through a navigation system and gets sent to Sarah Ferrara, who's our lead social worker for this project. She has a lot of experience in cognitive screening and used to do a lot of this at a memory loss center, actually, in her prior life. She's very good with the patients, and she normalizes the situation and puts patients at ease for what they're talking about, takes the fear out of the screening, and she does the initial screening. We do have a team of 5 social workers, so if the program grows, we can include all of those social workers within the screening. We also have 6 community health workers that we pair up often with our behavioral health team, and we've given them specialized training in initial outreach, initial simple screenings for many programs. Their specialty is communicating with our patients and being on the level of our patient population, and it's worked very well for us at Sharp-Reese-Sealy. So once the cognitive screening is done, if there's further follow-up that needs to be done immediately, the PCP is notified. If there is not follow-up that needs to be done immediately, they are put in a queue to follow up in 6 months to do the same screening. They're also offered case management services, not only for behavioral health, but for other chronic conditions they may have. We have a very large team of social workers and nurses that specialize in different areas. So some patients have wanted to have a case manager, which is really great. We love that. Okay, next slide. All right, so here's some of our opportunities, successes, challenges. We have an existing robust program. We were able to engage at the primary site. We've done a lot of education leading to the knowledge of this program, but as all of you know, you have to educate, and again, educate. And when we start a new program, it's rounding, and then reminding people exactly what we do. And I've worked here for 15 years, and they still ask, tell us again what Pop Health does. There's still people who ask that question. So that's always a little bit of a challenge and a problem solving. The pre-screening questionnaire we felt worked very well. We've used it with other areas. We've included depression screenings when we do. That's been a big push for our organizations. And in the past year, we've gone from 13% overall depression screening for all patients to a 71%. So we're very proud of that. And so we do include that with the program. And Sarah has said sometimes when patients seem to have issues with memory, it's more depression than cognitive issues. And she's been able to really see that in some of the assessments that she's done. We have very experienced people, and we love our community health workers. So we have staffing constraints, so we're not really going to hire anybody new for a very long time that we see. So it's just making sure that we're able to set up the program and use existing staff in a meaningful way. Epic is still new, although we just have now a brain health navigator assessment and program for our social workers that is beautiful, and we really, really love it. And it's going to be able to capture data for us. There's a lot of pockets of lack of understanding. We now have spread it to all of our sites, so that's new. And we're still not getting a lot of uptake on referrals for all the other sites, but that's our work now. We are unable to get billing started at all. We are in a line of billing opportunities. In fact, social work is one of them for many different areas. And because Epic is new and they're setting it up in Epic, we're on a list. So we haven't really been able to do that yet. So that will continue to be a little bit of a challenge. Saying that financial sustainability is difficult, but our plan is to really talk about people that were in brain health navigation being able to do well in their other chronic conditions, especially admissions to the hospital or consistent ED visits because the family doesn't know what to do. So that's how we pose to show our success in this area until billing can get started, which will give us some more meat to add to it. I would say choose your participating staff very carefully. And I think that everybody knows that who's on this call. And there are some people that are very skilled with our patients and very skilled with talking physicians and willing to take on more work than they already do, because Sarah, dear Sarah, has 100 patients in our case management program, and she's also doing this for us. And we
Thank you.
haven't, just
Oh,
one more.
sorry, Janet, I thought you were done.
All right, we haven't started to coordinate with neurology yet. That's next. And first we want to get things going. So
thank you, Janet. We really appreciate it. And we love that you're really taking this broad mental health look across, you know, mental illness around behavioral care, but also mental health in terms of, and brain health in terms of cognition. So we're excited to see what you guys do. Hey, Greg, tell us what's going on in Kentucky.
All right. So thank you. So I'm Greg Cooper. I'm the neurology side of this equation. Steve Patton is my primary care partner on this project. Stephanie Freeman coordinates our entire program, and Deb Lockridge does all of the work. So go on to the next slide. So Norton Healthcare is a medium to large size integrated healthcare system. We're centered in Louisville, Kentucky. So our primary catchment area is Louisville and surrounding counties, but we actually extend into suburban and rural populations, largely across Kentucky and southern Indiana to some surrounding states as well. We centered our Brain Health Navigator within the memory care program within our Neuroscience Institute, but then partnering with primary care and specifically with Dr. Patton's practice, which is a fairly diverse practice on the south side of Louisville. So next slide. So realize this is a fairly busy slide, but let me just hit a few of the highlights. So we begin with symptom presentation. I will tell you, we'd like to go even earlier than that, but that's where we're starting right now. And we put a real premium on flexibility. So symptom presentation may be at annual wellness visits or transition of care visits within primary care, but we allow for self-referral into the neurology program as well. We allow for referral from primary care to neurology. So we wanted to make that as flexible as possible with an eye on scalability in the future. From there, you can refer after qualifying visits straight into the Brain Health Navigator program, or really at any point along the pathway that you want to. Again, we want to preserve that flexibility. But at that point, patients will go through the diagnostic pathway. They'll go up to the point of treatment. If they haven't been referred to neurology, they certainly can be at that point. And in particular, if we're being considered for anti-amyloid therapies, certainly would refer to neurology at that point. Again, not to sound like a broken record, but at any point along that way, we can refer back into the Brain Health Navigator program if they haven't done so already. And then the other point, we see the Navigator as a point of connection. So we want the Navigator to be able to connect that family, the patient and their family, with other resources, both within the Norton Neuroscience Institute, our resource center, for example, but also to outside resources such as the Alzheimer's Association. So next slide. So this kind of summarizes some of the key points for us. So going into it, we had three main areas we were interested in. First of all, value creation. We want to create value for the patient and the family and for the other providers. We want to focus on flexibility. At the risk of sounding facetious, we want to make it so easy to refer into the Brain Health Navigator program that people accidentally find themselves there. We want to make it as seamless as possible. All roads lead to the Brain Health Navigator. And then we wanted to focus on financial sustainability. So looking at each of those, we spent quite a bit of time talking about what are the Brain Health Navigator roles. It may sound silly to say this as well, but all of us knew it was important but to really articulate what those roles and the value were was an iterative process. And these are the main ones we came up with: coordination, navigation, education and support, a really interdisciplinary collaboration, crossing across those disciplines, breaking down those silos, advanced care planning, and again, maybe it goes along with interdisciplinary collaboration. It's a liaison between primary care, specialty care, and internal and external resources. They're a connector. We support referrals from both primary and specialty care. So again, that flexibility. And then we leaned in pretty heavily from the very beginning on the billable navigation codes. And there are other codes. We really stuck with PIN and PCM codes. So next slide. So thinking about some of the things we've learned along the way, I think we did pretty well at this, but I would say it was critical to identify the stakeholders in the team. We wanted someone at a high level from an administrative standpoint. They didn't have to attend all our meetings, but when people knew they were in our corner, hard to say no to us. We needed people that had a really strong operational skill set so they could create, operationalize, implement the plan. And then you've heard it a couple times before, but you need tenacious champion or multiple champions. Fortunately, none of us were aware that we were allowed to fail, so that helped. But you need that team, and then you need to meet with them and communicate often. Again, this is an iterative process. What are the gaps? Where can we create value? How do we define those roles? And we continued to adapt over time. We wanted to be a continuously learning organization. Determine the appropriate billing codes. We did that early on, and I think that's critical when we talk about the long-term sustainability. And then communicate the value to the patient and family. I think this is something we stumbled a little bit to begin with. When I sat down to talk to families, I understand what the value is, but then I realized it wasn't that easy for me to articulate that in a succinct fashion. So that got us off to a little bit of a slow start, but we picked up speed once we got better at that. And the next slide. And so I think this kind of wraps it up for me. What are our successes? What are our challenges? I think without doubt, we have elevated our level of care, and the feedback we get from caregivers is remarkably positive. So we succeeded there, and I think that's one of the real strengths of this program. We created a referral process within Epic, our electronic health record. We certainly improved that multidisciplinary coordination. We got people talking across different sites of care more effectively. And we did improve early recognition, more efficient evaluation. The time from symptom onset to evaluation to diagnosis and treatment did shorten, perhaps more than I initially thought. What are the challenges? I think that we are still evolving in our definition of navigation. We've got a good message, but I think that will continue to improve over time. Initially, some of the referrals we got in probably weren't the right referrals. I think with better communication, we've tightened that process up pretty well. And then looking at sustainability, this is a part I'm fairly proud of. We now have over 100 patients that have been enrolled into the program. We have got very low rates of denial. So we're bringing in revenue for the navigation process itself. That's pretty good. But then if you start looking at the downstream revenue, the incremental evaluations, MRIs, lab draws, over a quarter of our patients have subsequently made it into anti-amyloid therapies. When you combine all that together, I feel reasonably confident about our sustainability and would argue actually that we're moving now into that second phase of sustainable operations and are starting to think about very seriously how we build upon this success to take on other projects and to grow this program. And that is me at Norton, us at Norton, I should say.
Thank you. Thank you, Greg. It's definitely an us game at Norton. And I think one of the things that you guys have been incredible about is getting your whole community rallying around you and your leadership really seeing how Norton can play a role in the community as leading in brain health. And I think that's obviously creating a lot of great support and surround sound for you. So thank you for that. In terms of the billing question, we did get a question while Greg was talking about billing codes. You can find the billing guide at the dacblueprint.org. We'll give you a QR code at the end. I'm a little worried we may not get to all of our questions. We're running a little long, but Rana, let's have you take it away at University of Cincinnati, please.
Okay. Thank you so much. I'm Rana Schatz. I'm a behavioral neurologist at University of Cincinnati, and I have a very wonderful team. Catherine Schmidt is the PCP lead, basic cheerleader, and optimist. And Paul is a learning health specialist and operations expert. We call her the Energizer Bunny. We have Candace Birch, an Alzheimer's Association social worker, more about that in a moment, who's the lifeline for our primary care docs and families. And not pictured here, but since this slide was made, we have our glue, Wanda Lehman, who is our RN brain health navigator. Next slide. Our healthcare system is an academic center. We have 5 subspecialty behavioral neurologists and a behavioral neurology nurse practitioner who receive the referrals for the system for cognitive evaluations before this project began. We also have 19 primary care clinics with 96 providers, and we serve over 500,000 patients a year. We have a new ambulatory geriatric center, which has enhanced our program. Our geographic catchment is similar to some of the other centers where, yes, we're concentrated in urban areas with populations that have difficulty getting to our centers, getting diagnosed, rural areas as far east as Appalachia, and areas of eastern Indiana, bits of northern Kentucky, not kind of knocking on Norton's door there. Next slide. In our evaluation of how we were going to approach this, we capitalized on a system vision that we had in which we wanted to organize our entire healthcare system towards brain health. And it was the ultimate goal for us to have a PCP-enabled prevention focus. And we saw the Brain Health Navigator for early detection as one stage of brain health. We thought it was very important to understand our local cultures. So we set out by surveying the primary care docs, and we found out that 41% of them wanted to diagnose and treat patients with Alzheimer's disease in their own practice. Contrary to what administrators thought, though, our primary care docs identified that there are lots of gaps in their clinical knowledge. There was a lack of structural systems for scheduling, diagnostic tools, billing, and I think mentioned in other discussions too, the real fear, okay, I diagnosed this, then what do I do? So and the next thing that we were really focused on was, what does our system need? And in our system, we wanted to enhance capacity, not referrals to neurology, because we had over 6 to 9 months of a wait time. So we wanted to grow more brain health specialists, and we created the PCP brain health subspecialty for diagnosing and treating Alzheimer's disease specifically. Neurology referral would be for atypical cases, negative or intermediate AD biomarkers, or for anti-amyloid therapy eligibility. We leveraged geriatrics for late-stage dementia, so there was an emphasis on goals of care, palliative and hospice enrollment. Next slide. And like everyone else's busy slide, I'll kind of break this down into an easier understanding. Our Brain Health Navigator receives referrals from general primary care physicians. And similar to many other systems, we have a very broad spectrum of what we accept as a reason to see the Brain Health Navigator. And we're leveraging other projects in the system to increase annual wellness visits. And we are accepting people who have a subjective complaint, somebody with an objective care partner, but encompassing the fact that presentations might not just be cognitive, but nuance at behavioral or motor syndromes. We're moving away from the idea that I think PCPs have used as a cutoff on a screening test. Then the Brain Health Navigator obtains consent for services and initiates all the studies that are necessary for diagnosis. And that includes the imaging, the blood-based biomarker, home sleep study. We have templated Epic tools for capturing symptoms, vascular risk, drug side effects, alcohol, and the labs for comorbidities. In partnership then, after the Brain Health Navigator orders those and speaks to the care partner is then referred to our Alzheimer's Association embedded social worker. This is a wonderful collaboration where the Alzheimer's Association locally saw this was an opportunity to reach more people. And so we share the cost of this social worker. And right away, families can be connected to someone who can meet their immediate needs, but also really help understand more of the process. The social worker also obtains very needed information for the PCP, which is the ADLs and a broad spectrum of behaviors and mood changes. And then finally, in this pathway, after all this information has been obtained, the patients and care partners meet with the primary care specialist. And at this visit, a diagnosis is given. There is a staging. And based on that staging, a triaging, both with the diagnosis and the staging. So if it's an Alzheimer's positive profile, and all studies suggest that, and they're mild cognitive impairment or mild dementia and anti-amyloid therapy eligible, they're referred to neurology on a fast track. If they're mild cognitive impairment to moderate but not eligible, initial medications are given. There's a discussion of lifestyle, sleep, and control of risk factors. And then if AD is not, if the markers are indeterminate or not AD, they're fast-tracked to neurology for additional evaluations. Next slide. So a few things kind of summarizing our successes. We've been able now to scale this. We had initially 2 PCPs. They're very experienced, and they have joined 6 other PCPs in getting this process together to be a specialist. We have a dedicated Brain Health Navigator nurse now. We had initially pushback from our administration on hiring someone just that who might be part of a project but not sustainable. We have been able to expedite neurology referrals for all the situations identified earlier. So much tighter and faster evaluations. We have, and continuing to do, Epic tool development. Very important to make this so easy for the PCP. Our challenges initially were billing. That's what put us behind in actually having a Brain Health Navigator. I will tell you, we created a sort of a superpower by going to other places in the system that had had navigation, oncology, and population health. No one had been billing because our administration thought you couldn't. And we got a secret weapon in the Davos availability of Grace Showalter, who's been able to work with our system to really identify the fact, yes, you can bill and solve all the issues of the problems that were hospital-based. Our digital cognitive assessment tool has been key in the workflow, but the one that we had piloted and primary care loved has gone offline because they were bought. So we're looking for a new one. And then I think what we have found is there's still distrust by primary care docs on believing a blood-based biomarker when somebody can talk with them in the interview. And case detection, as other people have mentioned, is still hard. There is, I think, still this fear of and stigma and perception of Alzheimer's disease at a much later stage. And our message to our PCPs, it's not your grandmother's Baba Yaga story anymore. It's also
Thank you, Rana.
yeah.
I'm going to keep us moving because I want to make sure we get to Sue, but thanks for highlighting the partnership with the Alzheimer's Association. Deb Cherry actually asked that question, so I think that's a really good model. And then also thank you for sharing kind of some of the challenges around billing. There's been a lot of questions about billing in the chat. I've answered them, but recognize there are billing guides and toolkits on the BHN site at www.dacblueprint.org. Okay, Sue, bring us home.
Hi, everybody. I'm Sue Borson, and I'm going to cut mine pretty short because there needs to be enough time for conversation after. I will try to be as quick as I possibly can. This is our team representing family medicine, neurology, internal medicine, in the implementation of our Brain Health Navigator program. USC is a different kind of institution than the ones that you've been hearing about. It was developed as a high-level specialty program, especially for surgical specialties, and primary care is a relatively late development. Most of what's happening in primary care at USC is for training purposes of a small residency programs, but also the development of partnerships across the geographic region with primary care groups. Those developments, the primary care partnerships for USC are in active development and are not represented here at this stage, except for one, and that is the county hospital, our safety net system in Los Angeles. Next, please. What's different about USC is that it started with technology. USC leadership purchased the license for a digital cognitive assessment and then had to figure out how to put it into play. So that's where the Brain Health Navigator program came in. The system was not really prepared to think in terms of population health. This is not a medical environment in which population health has been the primary priority. It's really been about science and development of new technologies and the implementation of technologies to see how they work. So in our Brain Health Navigator model, we chose to pick a non-clinical healthcare worker. This might be a community health worker or other. In this case, our Brain Health Navigator is someone who worked for several years as a research assistant in the Alzheimer's Disease Research Center, which is very, of course, heavily focused on research and implementation of novel therapeutics. So the path starts with a concern on the part of a patient, a family, or a clinician in family medicine or internal medicine about cognitive impairment. The referral then goes electronically to the Brain Health Navigator for a first stage assessment and a protocolized coordination of next steps. Our goal, of course, is to support everybody in the journey, from primary care clinicians through patients and families and memory specialists, by streamlining the process of getting the right patients to neurology and developing care pathways within generalist management paradigms. Next, please. So our model looks a little bit simpler, but you're going to recognize a lot of commonalities with what you've already heard. So starting with a concern or with an abnormal screen and an annual wellness visit, a referral is placed to the BHN. The BHN then does a rather complicated but questionnaire-based assessment, including the digital cognitive assessment, vision, hearing, depression, etc., and a screen for high-risk meds and behavioral problems and caregiver burden, if any. Then the BHN uses the protocol to explain findings from the initial assessment to the patient and care partner, then sends the initial results to the primary care clinician with recommendations for further workup or referral to neurology or someone else, such as geriatrics, and then helps to schedule appointments and follow-ups to triage questions, retrieve medical records, and document all the services provided. Next, please. So our goal here was to, among other things, tailor referrals to neurology. The neurology program wanted people who had complex neurological problems associated with cognition, where neurologists can be of greatest value in the health system, but also to keep a steady stream of referrals for implementation of novel therapeutics. In this case, anti-amyloid antibody therapies. So we were careful to look at what patients should not be referred to neurology. That's none of these 5 situations apply, and shouldn't go to neurology and may not need a BHN evaluation either. So if there's a known cause already of cognitive impairment, probably not to the BHN. Other major medical problems such as chemotherapy and stage renal disease, advanced heart failure, nope. Obvious, moderate, or severe dementia, probably not. Already in hospice or palliative care, no. And obvious neurological findings that are visible to everyone, a lot of tremor, Parkinsonism, and so forth. So we have pathways for each of these groups and a way of winnowing down the potential referral population to those most likely to benefit from the BHN and linkage to neurology. Next, please. So this is really just how we think about doing it. Our digital cognitive assessment is the core cognitive evaluation using the Linus platform. So I'm going to move on from this because this is really similar to what you've already heard. So what did we build on, and what may we be able to do in a system like this? So we had tremendous assets in a mature Alzheimer's disease research center and cognitive neurology program that was an early adopter of disease-modifying anti-amyloid therapies and is across ADRCs in the country among the top 3 users of these therapeutics. We had a highly qualified new, although non-licensed, non-clinical brain health navigator, and a lot of leadership enthusiasm for the digital cognitive assessment. There is unified primary care leadership across family medicine and internal medicine that's now being enriched with new faculty expertise especially in geriatrics, and momentum for primary care innovation and age friendliness, although because this is not a primary care driven system, it lives in its own environment. There's tremendous amount of active Alzheimer's disease research across multiple disciplines, schools, and centers at USC, which has yet to be, that's one of our greatest points of leverage, I think, is to be able to bring together these different scientific endeavors and link them and unify them with the clinical mission. So I want to focus just on one particular opportunity we have that I think is special, and that is to implement early detection strategies within our safety net system. This is because of how California has chosen to prioritize early detection of dementia by requiring of all doctors who are caring for patients over 65 who are on Medicaid. All such patients now must have an annual cognitive health screen. And that is a very simple cognition function-based screener that is designed for use in the Medicaid population, which is the dominant population, of course, in our safety net system. So what's happened there is cognitive health assessment has already begun in the safety net. And what's new is that neurology now has a presence there that it has not had with regard to dementia. So there's now the opportunity to develop a clear pathway within the safety net system from primary care to cognitive neurology on site within the system. So that may be it. Do we have any more? That's it. Thank you.
That's it. Thanks, Sue. We are going to, I'm going to show 2 slides, and then I'm going to ask the panelists one final question. So I think the next slide is really just for everyone's information. Everything you've heard today, not only is the recording going to be available and the slides will be made available, but these fantastic sites have put together tools for all of you. And you've heard there's basically 3 things. There's the care workflows, there's the billing and business cases, and there's training and education. All of this material is available to everyone on this call, and it's completely open access. So please go take a look at it, and you should find at least a good start on the things that you need to get your system started. You'll see the QR code is there, or you can find it at www.dacblueprint.org. I have to say a huge thank you to this team. You saw a brief snapshot just then of this group together. We actually did all of this work in 9 months virtually. And so we spent a lot of time on Zoom, and a big thank you to all of them. I also want to thank our sponsors. This would not be possible without our sponsors. You can see an entire list of sponsors on the DAC website, Davos Alzheimer's Collaborative.org. A special thanks to ASI for their funding for this program. So one final question. Let's do this maybe in the order you guys presented. If you had one piece of advice, so Dax, it's coming to you first. What piece of advice would you give to the folks that are listening today?
I mean, I think the one piece of advice I would give is don't feel hobbled by a lack of specialty expertise of one kind or another. Is that I think it's been pretty clear that from the very different setups and specialties that are involved, anyone can do a good job of making this system work. It's just finding the right shareholders and finding the right champions that can help figure this out at any one health system.
Thank you. Kara.
I think it would be early on to identify a project manager that can link the administrative and the clinical piece of this, and that has the time to coordinate all of those things, coordinate meetings with the 2 groups, keep the process moving forward.
Great. Thank you. Janet. Uh-oh, I think you might be muted.
Sorry, I would say don't get discouraged early on if it's not going as smoothly and quickly as you want it to. Just keep plugging away and you'll see success.
I love it. Thank you. Well, and have a team. Sometimes our community of practice meetings sounded a little bit like therapy sessions. So find someone. This group I know will make themselves available to folks as well, because we're all trying to make this change together. Greg, what's your piece of advice?
Start with the right team and then obsessively communicate.
Love it. Love it. Rana?
Don't be afraid to look outside your system for the resources you don't have. They're in the community, they're somewhere.
I love it. Sue?
Recognize that readiness is iterative. And one part of your system may be ready and the other absolutely not. But we can keep pulling each other along as we go.
I love it. I love it. Well, I wanted to let people know we did have a couple of questions about like, how's your weight been shortened? How do you use blood tests? keep following the Davos Alzheimer's Collaborative, because this group is going to continue to collect data through the end of the year. They will each be putting final reports together that talks about their workflows, what they learned, both qualitatively and in terms of patient flow. Obviously, it's been a very short program, so we're not going to see, massive, 9 months down to 9 weeks, although I do think we actually have some really good triage examples that gives us a sniff that we're headed that direction. And then I expect this group will continue to report out both in medical literature as well as through the Davos Alzheimer's Collaborative. So continue to follow us here. My one piece, I'm going to go back and steal something that Dennis said at the very beginning. And if you remember, he said you have to have heart and head. And I think this group has demonstrated to you that they clearly have the head and the mindset to do this, but they also have the heart. It change isn't easy, but those that really want to make it so. And we never want to lose the patient in the forefront of our ideals. And we actually had a patient with us in New York City recently for a DAC breakfast. He was a patient who actually was early detected. He did get an accurate diagnosis. He was put on one of the new anti-amyloid therapies, and his plaque is no longer at those detectable levels, and he's living a full and robust life. And his message to all of the health systems that were there from New York City and New York State was, take the test. And my thing is, let's take the challenge. And thank you to all of you for being such wonderful partners. We're excited to see what happens at all of your systems going forward. Thank you, everyone, for joining us today. This will be recorded and put out for the field. Please feel free to be in touch with us. We look forward to working with all of you. Take care.